Good afternoon, students. In today's class, we are going to cover ovarian lesions. The entire presentation I have prepared, keeping in mind, specifically keeping in mind your Robbins textbook. All the notes, all the slides I prepared from that book only, so that if you pay attention to today's class and then you go ahead and open the Robbins textbook, you'll be able to cover everything within 5 to 10 minutes, because all the notes are from Robbins only. Anything extra you want to add, you can add from Robbins also. Basically, the purpose is to make Robbins more approachable to you. Okay, introduction to ovaries. The ovarian surface is covered by a single layer of cells called the germinal epithelium that overlies the dense, irregular connective tissue, tunica albuginea. This is located under the tunica albuginea. We have the cortex of the ovary. The cortex, it contains follicles and oocytes that are present at various stages of development and degeneration, made up of tightly packed connective tissue, and the stroma of this cortical connective tissue is composed of fibroblasts. Deep to the cortex is the highly vascularized connective tissue core of the ovary, also known as the medulla. There is no distinct boundary line between the cortex and medulla, and these two regions blend together. Here, the ovarian vasculature is found and is primarily loose stromal tissue. All the features that I've talked about can be understood in this panoramic view of the ovary, histological panoramic view of the ovary. We can see here that we have a cortex, and also in the center of this diagram you can see there is an area with blood vessels which has been labeled as medulla with blood vessels. Among other things, there is labeled, we can see mature follicle, we can see the corpus albicans, we can see the cortex has been labeled if for your perusal. We have primary oocytes and primary follicles. Also, I would like you to take note that the outermost layer in this picture, the epithelium, which is also known as a germinal epithelium, it is a derivative of Mullerian epithelium. This point you'll have to remember when we are discussing ovarian tumors arising from the epithelium, that is epithelial ovarian tumors. Here is another photo of the microscopic features of the ovary. Here, this photo is also giving a summary of the stages of development of all the follicles. We have primary follicles, then we have oocyte, we have secondary follicle, then we have Graafian follicle, okay, and finally we have a ovulated oocyte, and then that follicle degenerates to corpus luteum. Here is a brief look at the ligaments related to the ovary. Here is another brief look at the blood supply and the nerve supply of the ovary. As we can see, blood supply is derived from the ovarian artery itself and also branches of the uterine artery, which itself is a branch of the internal iliac artery. The drainage is by ovarian veins. The right ovarian vein drains directly into the inferior vena cava, left drains into the left renal vein. Nerve supply, the sympathetic one is by ovarian plexus and parasympathetic one is by uterine plexus. Now that we have discussed the basic anatomy of ovaries, we will now start looking at the lesions. The most common ovarian lesions encountered are functional or benign cysts and tumors. Neoplastic disorders can be grouped according to the origin from each of the three main ovarian cell types, that is Mullerian epithelium. Remember, I had discussed just now the epithelium of the ovary, the germ cells, and the sex cord stromal cells. Primary inflammations of the ovary, that is oophorytis, are uncommon and on rare occasions may have an autoimmune basis. The autoimmune reactions affect the ovarian follicles and may lead to infertility. So now we'll begin with the non-neoplastic and functional cysts of the ovary. First, we'll discuss follicular cysts. Cystic follicles are very common in the ovary. They originate from unruptured Graafian follicles or in follicles that have ruptured and immediately sealed. They can be single or multiple. These cysts are usually multiple. They range in size up to 2 cm in diameter. They are filled with a clear serous fluid and are lined by gray glistening membrane. On occasion, larger cysts exceeding 2 cm may be diagnosed by palpation or ultrasonography, and these cysts sometimes they may cause pelvic pain. As we can see here, the gross and the microscopic photo are there. The granulosa lining cells are present if the intraluminal pressure has not been so great as to cause atrophy. The outer theca cells may be conspicuous due to increased amounts of pale cytoplasm, a change which is referred to as luteinization. When luteinization is pronounced, which is also known as hypertrichosis, it may be associated with increased estrogen production and endometrial abnormalities. As we can see in the picture here, the gross photo is showing us 3 to 4 follicular cysts along with a corpus luteum. And in this photo we can see this is the lining of the cyst that is being shown in the photomicrograph here. In the lining we can see granulosa cells, some of which have been luteinized, and outside that beneath that are the theca cells. Now we'll look at the luteal cyst of ovary. Till now we were discussing follicular cyst. Now we are looking at luteal cyst or corpus luteal cyst. It is an ovarian cyst which is more than 3 centimeter in diameter, and it is lined by luteinized granulosa and theca cells. Now I'd like you to pay attention to this fact that if it is 3 centimeter, more than 3 centimeter, only then it is called a corpus luteal cyst of ovary. If it is less than 3 centimeter, it is called a cystic corpus luteum, and it is considered physiologic. And the cyst lining is composed of layers of luteinized granulosa cells with abundant cytoplasm overlying small theca cells. So now you will ask, then both the follicular cyst and the luteal cyst are having luteinized granulosa cells and theca cells. What is the difference? The difference is that the origin. See, when the follicle fails to rupture and continues to grow, a follicular cyst occurs. When the corpus luteum fails to involute and continues to grow, a corpus luteal cyst occurs. Okay, both types of cysts are considered physiologic or functional, and neither have much malignant potential. And another thing to remember is corpus luteum cysts are generally very much large. As we have already discussed, corpus luteum cyst is more than 3 centimeter, whereas a follicular cyst, as we have seen in the slide, follicular cysts generally range up to size in 2 centimeter only. Now we'll discuss polycystic ovarian syndrome. Polycystic ovarian syndrome is a complex endocrine disorder characterized by hyperandrogenism, menstrual abnormalities, polycystic ovaries, chronic anovulation, and decreased fertility. It was formerly called Steen-Leventhal syndrome, and it affects 6 to 10% of women of reproductive age. It is also associated with obesity, type 2 diabetes, and premature atherosclerosis, all of which may be indicative of an underlying metabolic disorder. The etiology of PCOS remains incompletely understood. Many etiological factors have been implicated, some of which are sedentary life, diet, stress, genetic factors like CYP21 gene, familial, that is sex-linked mode of inheritance, environmental, obesity is also a factor, BMI more than 30, uh, uh, extremely sorry for the disturbance. We'll continue where we left off. The many etiological factors have been implicated. Sedentary life, diet, stress, genetic alterations like CYP21, mutations of CYP21 gene, familial factors have been implicated, environmental factors have been implicated, obesity, and BMI more than 30 kg per meter square, waistline more than 88 centimeter, waist to hip ratio of more than 0.85 have been implicated. Here is a photo for you to understand difference between normal ovary and polycystic ovary. As we can see, the polycystic ovary is having multiple immature follicles. Here is another photo to give you an idea between a normal ovary, which is shown on the left here, and the polycystic ovary, which is shown on the right. Another picture showing ultrasound picture of the polycystic ovary versus that of a normal ovary. Pathogenesis of the polycystic ovarian disease. It is marked by a dysregulation of enzymes involved in androgen biosynthesis and excessive androgen production, which is considered to be a central feature of this disorder. As you can see in the flowchart that I have included, in the flowchart also at the center and very nicely written in bold letters is androgen excess. You can see that at the androgen excess due to various factors like increased LH-FSH ratio due to hyperinsulinemia, which is in turn due to insulin resistance, which is in turn due to the etiological factors which we discussed just now, for example, obesity, sedentary lifestyle, and genetic causes. This androgen excess is only in causing the hirsutism, the alopecia, the acne. It is causing arrest in antral follicle development, therefore causing anovulation and polycystic ovaries, anovulatory bleeding, and then subfertility. All of it is being caused by androgen excess only. In addition, women with PCOS show insulin resistance and altered adipose tissue metabolism, which contribute to development of both diabetes and obesity. We'll quickly take a look at the histopathological features. Also, the central morphologic abnormality of PCOS is numerous cystic follicles or follicle cysts that enlarge the ovaries. However, polycystic ovaries are detected in 20 to 30% of all women, so this finding is not specific. In addition, due to an increase in free serum estrone levels, women with PCOS are at risk of endometrial hyperplasia and carcinoma. As we can see in the pictures included, the first picture being a gross photograph where we can see an enlarged ovary with pearly white multiple cysts, and also in this ovary only we can see these multiple cysts are visible beneath the surface, though it's not a very distinct outpouching, but we can make out that underneath the surface there are multiple cystic structures. But then of the same ovary, if we see the histopathological section, the second photo, we can see that the outer cortex is collagenized, and underneath we can see several follicle cysts, one by one, all so many follicle cysts we can see. Stromal hypertrichosis, also called cortical stromal hyperplasia, is a disorder of ovarian stroma most often seen in postmenopausal women, but it may overlap with PCOS in younger women. The disorder is characterized by uniform enlargement of the ovary up to 7 cm, which has a white to tan appearance on sectioning. The involvement is usually bilateral and microscopically shows hypercellular stroma and luteinization of the stromal cells, which are visible as discrete nests of cells with vacuolated cytoplasm. The clinical presentation and effects on the endometrium are similar to those of PCOS, although virilization may be even more striking. A physiologic condition mimicking the aforementioned syndrome is theca lutein hyperplasia of pregnancy. In response to pregnancy hormones, that is gonadotropins, theca cells proliferate and perifollicular zone expands. As the follicles regress, the concentric theca lutein hyperplasia may appear nodular. This change is not to be confused with true luteomas of pregnancy. Now that we have discussed the non-neoplastic lesions of ovary, we'll begin with ovarian tumors. Students, keep in mind the only classification that you need to know for your exam is this one, which has been given in Robbins, and I have included on the right side of this slide. This is the only classification you need to remember and nothing else. There are numerous types of ovarian tumors. About 80% are benign, and these occur mostly in young women between the ages of 20 and 45 years. Borderline tumors occur at slightly older ages. Malignant tumors are more common in older women between the ages of 45 and 65 years. Because most ovarian cancers have spread beyond the ovary by the time of diagnosis, they account for a disproportionate number of deaths from cancer of the female genital tract. So let us begin with the epithelial tumors. Most primary ovarian neoplasms arise from Mullerian epithelium. The classification of these tumors is based on both differentiation and extent of proliferation of the epithelium. There are three major histologic types: serous, mucinous, and endometrioid. These epithelial proliferations are classified as benign, borderline, or malignant. The benign tumors are often further subclassified based on the components of the tumor, which include: if they have cystic areas, they will be cystadenomas; if they have cystic and fibrous areas, they will be cystadenofibromas; and if they are predominantly fibrous, they will be adenofibromas. The borderline tumors and the malignant tumors can also have a cystic component, and when malignant, they are sometimes referred to as cystadenocarcinomas. So now that we know what the benign, the malignant, and the borderline, the benign, the borderline, and the malignant tumors can be cystadenomas, cystadenofibromas, or cystadenocarcinomas. Now that we know that, let us look at the various types of epithelial tumors. First is serous tumors. These cystic neoplasms include the most common malignant or ovarian tumors and account for approximately 40% of all cancers of the ovary. Although the term serous appropriately describes the cyst fluid, it has become synonymous with the tubal-like epithelium in these tumors. The together benign, borderline, and malignant types of serous tumor account for about 30% of all tumors and just over 50% of all epithelial ovarian tumors. About 70% are benign or borderline, and 30% are malignant. Benign and borderline tumors are most common between ages 20 and 45 years. Etiopathogenesis also will take a brief look at etiopathogenesis for serous epithelial tumors of ovary. Little is known about the risk factors for benign and borderline tumors. Risk factor for malignant serous tumor are also incompletely understood, but nulliparity, family history, and heritable mutations play a role in tumor development. There is a higher frequency of carcinoma in women with low parity. The estimated risk of ovarian cancer in women bearing BRCA1 and BRCA2 mutations is 20 to 60% by the age of 70 years. Another point of historical significance is that initially it was thought that the vast majority of serous ovarian carcinoma arose from cortical inclusion cysts. As we can see on the picture here, right, they were believed to be cysts that arise through invagination of the surface epithelium followed by serous metaplasia. It was believed that these inclusion cysts were the reason for serous carcinoma, but now there have been now more other theories are available which implicate the BRCA1 and BRCA2 gene and also nulliparity and family history. Serous tumors may present as either a multicystic lesion in which papillary epithelium is contained within a few fibrous walled cysts or as a mass projecting from the ovarian surface. As we can see in the photo included here, the gross appearance of serous tumors. First photo is showing us a borderline tumor where upon cutting the cyst, we can see that the cyst cavity is lined by delicate papillary tumor growths. And in the second photo, that is B, we can see carcinoma. The cyst is open to reveal a large bulky tumor mass. And last photo, that is C, we are seeing another borderline tumor growing on the surface of the tumor. Benign tumors typically have a smooth glistening cyst wall with no epithelial thickening or with small papillary projections. Borderline tumors contain an increased number of papillary projections, larger areas of solid or papillary tumor mass, tumor irregularity and fixation or nodularity of the capsule are features associated with malignancy. Microscopically, the cysts are lined by columnar epithelium, which has abundant cilia in benign tumors. Microscopic papillae may be found. Serous borderline tumors exhibit increased complexity of the stromal papillae, stratification of the epithelium, and mild nuclear atypia. But invasion of the stroma is not seen. These epithelial proliferations often grow in a delicate papillary pattern referred to as micropapillary carcinoma, which is thought to be precursor to low-grade serous carcinoma. High-grade serous carcinoma, on the other hand, are distinguished by having more complex growth pattern and widespread infiltration or frank effacement of the underlying stroma. The individual tumor cells display marked nuclear atypia, including pleomorphism, atypical mitotic figures, and multinucleation. The serous tubal intraepithelial carcinoma consists of cells morphologically identical to high-grade serous carcinoma but are distinguished by the lack of invasion. The cells of invasive high-grade serous carcinoma can even become so undifferentiated that serous features are no longer recognizable. So we were discussing that the cells of invasive high-grade serous carcinoma can even become so undifferentiated that serous features are no longer recognizable. We will now look at the microscopic picture of serous tumors of the ovary. The first photomicrograph here is showing the serous cystadenoma, that is showing stromal papillae with a columnar epithelium. The second photo is the borderline serous tumor showing increased architectural complexity and epithelial cell stratification. The third photo is showing complex micropapillary growth, which defines a low-grade micropapillary serous carcinoma. And the last picture, that is D, is showing a high-grade serous carcinoma with invasion of the underlying stroma. Next up is mucinous tumors. The mucinous tumors account for 20 to 25% of all ovarian neoplasms. They occur principally in middle adult life and are rare before puberty and after menopause. The vast majority are benign or borderline tumors. Primary ovarian mucinous carcinomas are uncommon and account for approximately 3% of all ovarian cancers. Pathogenesis: mutation of the KRAS proto-oncogene is a consistent genetic alteration in mucinous tumors of the ovary, including the majorities of benign mucinous carcinomas, that is 58%, mucinous borderline tumors, that is 75% to 86%, and ovarian mucinous carcinomas. KRAS mutation may initiate the development of these neoplasms. The mutations that collaborate with KRAS mutation to generate mucinous tumors are largely unknown. Here we have the gross and microscopic photograph. In mucinous tumors, the surface of the ovary is rarely involved, and only 5% of primary mucinous cystadenomas and mucinous carcinomas are bilateral. Mucinous tumors also tend to produce larger cystic masses compared to serous tumors. They are multilocular tumors filled with sticky gelatinous fluid rich in glycoproteins. Microscopically, the benign mucinous tumors are characterized by a lining of tall columnar epithelial cells with apical mucin that lack cilia. The vast majority demonstrates gastric or intestinal type differentiation, with uncommon tumors showing endocervical type mucinous differentiation instead. Mucinous borderline tumors are distinguished from cystadenomas by epithelial stratification, tufting, and/or papillary intraglandular growth. As we can see in these photos here, the first is a gross picture where we can see that the appearance is a multicystic appearance with delicate septa and presence of glistening mucin within the cysts. And the second photo is showing us the lining of these cysts, which is columnar cell lining with apical mucin. And here is a photomicrograph of mucinous adenocarcinoma. The carcinomas characteristically demonstrate confluent glandular growth that is now recognized as a form of expansile invasion. Stromal invasion, also more solid growth, atypia, stratification, papillae, loss of glandular architecture, and necrosis, greater complexity of glands than borderline tumors. These are all features of carcinoma. Stromal invasion may be infiltrative with disorderly penetration of stroma by neoplastic glands, single cells, or cell clusters, and they may have a desmoplastic response or expansile invasion with complex arrangement of glands, cysts, or papillae lined by malignant epithelium with minimal or no intervening stroma with a broad, sharply defined border. The glands are almost always intestinal type. As we can see in this photo here, the tumor, that mucinous adenocarcinoma, it is a well differentiated tumor, and in this instance we can see that it's showing a cribriform pattern. And on the top left or top right part of this picture, we can see a villous portion of the tumor, which has appearance of which is looking like a borderline tumor. Another thing that we need to discuss when we are discussing mucinous tumors is the phenomenon of pseudomyxoma peritonei. It is a clinical condition which is marked by extensive mucinous ascites, cystic epithelial implants on the peritoneal surfaces, adhesions, and frequent involvement of the ovaries. As we can see in the photos here, the first one being a gross picture view at laparotomy, it is revealing massive overgrowth of a gelatinous metastatic tumor. The second photo is histology of peritoneal implants of an appendiceal tumor showing mucin producing epithelium and free mucin. So basically what we are saying is that the pseudomyxoma peritonei phenomenon occurs when there is seeding of distant sites, especially of the ovaries, due to an appendiceal tumor, especially a mucinous appendiceal tumor. Endometrioid ovarian tumors. Endometrioid carcinoma accounts for approximately 10 to 15% of all ovarian cancers. Benign endometrioid tumors called endometrioid adenofibromas and borderline endometrioid tumors also occur but are uncommon. Endometrioid tumors are distinguished from serous and mucinous tumors by the presence of tubular glands resembling benign or malignant endometrium. Endometrioid carcinomas may arise in the setting of endometriosis and are occasionally associated with areas of borderline tumor. Pathogenesis. About 15 to 20% of cases with endometrioid carcinoma coexist with endometriosis. The peak incidence of tumors associated with endometriosis occurs a decade earlier than that of endometrioid carcinomas that are not associated with endometriosis. Molecular studies have found striking similarities to endometrioid carcinoma. Shared features include relatively frequent alterations that increase PI3K or AKT pathway signaling and mutations in mismatched DNA repair genes. and CTNNB1 gene. So one by one we'll see. First we see the endometrioid cystadenoma. It is a cystic tumor with endometrioid features. It may have squamous modules, ciliated or mucinous features. There will be no cytologic atypia, no architectural complexity, and benign lesions may be adenofibroma, adenoma, or cystadenoma. Then we have the endometrioid carcinomas, which typically present with solid and cystic areas of growth. 40% involve both ovaries, and such bilaterality usually implies extension of the neoplasm beyond the genital tract. These are low-grade tumors that reveal glandular patterns bearing a strong resemblance to those of endometrial origin. As we can see in the photomicrographs here, the first one is showing endometrial cystadenoma and is lined by cuboidal to columnar epithelium that is having no cytologic atypia. And we can also see that this lining is resembling that of an endometrial lining. The second photograph is again showing us a closer view where we can see that the gland resembles that of a normal endometrial gland. Uh, this photo on the other hand is showing us a endometrioid carcinoma, where we can see it is showing us a well differentiated villo-glandular pattern. And we can see here that the lining is having a stratification. The lining is showing a stratified columnar epithelium, and also the cells are showing atypia. Endometrioid carcinomas make up to 10 to 25% of all primary ovarian carcinomas, as we have already discussed earlier. Next epithelial tumor that we will discuss is the transitional cell tumor of ovary. Transitional cell tumors contain neoplastic epithelial cells resembling urothelium and are usually benign. They comprise roughly 10% of ovarian epithelial tumors and are also referred to as Brenner tumors. These neoplasms may be solid or cystic, are usually unilateral, and vary in size from small lesions less than 1 centimeter to massive tumors up to 20 to 30 centimeters. The fibrous stroma resembling that of normal ovary is marked by sharply demarcated nests of epithelial cells resembling the epithelium of the urinary tract or urothelium, often with mucinous glands in the center. As you can see in the photo here, the first photo being the gross picture, which is showing the the first photo, which is showing us the gross picture. On the right of that photo we have the transitional cell tumor, and on the left of that photo we have a cystic teratoma. Thus both of these are occurring together. As we can see in this particular example, we can see they're occurring together. And the Brenner tumor here is showing a solid pattern. Then we can see the picture on the right, that is B. It is showing us histological detail of the characteristic epithelial nests within the ovarian stroma. This is further shown much. This is shown much better in these photomicrographs. We can see here how the cystic spaces are lined by transitional or flattened or cuboidal or columnar epithelium. The squamous metaplasia or prominent mucinous change may be seen within some nests. The transitional cells have pale eosinophilic or clear cytoplasm, uniform round or ovoid nuclei, which may have lobes, fine chromatin, and punctate nuclei, and there is no cytologic atypia. In the benign Brenner tumor, the stromal component resembles ovarian fibroma or thecoma. It may become hyalinized or show dystrophic calcification. On the other side, we can see borderline Brenner tumor, where these tumors are composed of transitional epithelium with proliferative changes. They have papillary and polypoid areas, and this resembles low-grade papillary urothelial carcinoma. Therefore, this becomes the main difference between benign Brenner tumors and borderline Brenner tumors. Lastly, we will discuss borderline and malignant Brenner tumors. This makes up of 5% of all Brenner tumors. The majority of patients are over 50 years of age. The presentation is usually abdominal mass or pelvic pain. Grossly malignant Brenner tumors are large and may be cystic with mural nodules or entirely solid. Malignant Brenner tumors are composed of cytologically malignant transitional cells with stromal invasion, a component of typical benign Brenner tumor, which can be seen in the top of this image, is present within the tumor. Now, one point I would like you to understand is that when we are talking about the benign counterparts of transitional cell tumors of ovary, we can use the term Brenner and transitional cell tumor synonymously. For the benign and the borderline, we can simply call it benign Brenner tumor or borderline benign Brenner tumor or borderline Brenner tumor. But when we are talking about the malignant counterpart, there are two no, there are two distinct nomenclature. One is uh, malignant Brenner tumor, and another is transitional cell carcinoma of the ovary. When do we call it malignant Brenner and when do we call it transitional cell carcinoma? When the tumor has, as we have discussed earlier, when the tumor has a benign component also. When along with the malignant Brenner component, the tumor is also showing us a benign Brenner tumor component, that time we call it a malignant Brenner tumor. But when there is no benign component seen, when all we see is only the transitional cell carcinoma part that is resembling the malignant Brenner tumor, but it is lacking a benign and borderline Brenner element, that time we simply call it as transitional cell carcinoma of the ovary, as seen in this photo. Now, the last type of epithelial tumor of ovary that we'll discuss is clear cell tumors of the ovary. Clear cell cystadenoma or adenofibroma is a benign tumor composed of simple glands lined by bland cuboidal or flattened cells with clear or lightly eosinophilic cytoplasm in a background of fibromatous Adenofibromas have a more prominent stromal component as compared to cystadenomas. They are uncommon tumors usually seen in association with endometriosis and may be discovered incidentally. Grossly, they are solid tumors with a smooth external surface. The cut surface is solid, gray-white with small cysts. Clear cell adenofibroma, and we have already discussed that they are composed of simple glands with round or oval shape. They are lined by simple cuboidal or flattened epithelium, as we can see here, with clear or lightly eosinophilic cytoplasm. In this photo, we are seeing uh, cuboidal to columnar cells with clear cytoplasm, the lining we can see here. There is no cytologic atypia or increased mitotic activity, and solid sheets of clear cells or foci with papillary architecture are not seen in the benign counterpart, that is the adenofibroma counterpart. Areas of endometriosis are often present. But after discussing clear cell adenofibroma, we should also look at the borderline clear cell adenofibroma. Here we can see that the tumor is composed of entirely benign areas, but cytologic atypia is evident in the small nests. As we can see here, there are small nests here which are showing cytologic atypia. The larger dilated glands are lined by flattened epithelium and they are not showing any atypia, but we are seeing some small nests with atypia. Elsewhere, we can see multi-layering and pseudostratification with mild nuclear atypia. Lastly, we have clear cell carcinoma, which is the completely malignant counterpart. Clear cell carcinomas of the ovary show a variety of architectural patterns and many different cell types, admixed in various proportions. The most common patterns are tubulocystic, as shown here, papillary, and solid. Some areas are composed of cystically dilated glands lined by cuboidal atrophic appearing flattened epithelium. The tubules and cysts commonly show interluminal eosinophilic or basophilic secretions. Okay, here we are seeing the tubulocystic pattern of clear cell carcinoma of ovary. But in these two pictures, the first picture on the left, we can see the solid pattern of the clear cell carcinoma of ovary, where we can see the hobnail cells. And on the right, we can see the papillary architecture of the papillary variant of the clear cell carcinoma of ovary, where we can see papillary fronts, variable size papillary fronts can easily be made out and is having a complex architecture and hyalinized cores. Now that we have dealt with all the surface epithelial tumors of ovary, we will now take a quick look at all the germ cell tumors of ovary. Germ cell tumors originate from primordial germ cells and make up of 30% of all ovarian tumors. 95% of these are benign cystic teratomas. Usually occurs in young adolescent girls less than 25 years. And in this photo, which has again which has been lifted directly from your Robbins, a very nice diagram has been given to help you remember what are the various germ cell tumors. The first one being dysgerminoma, and the other one which come under the heading of embryonal carcinomas. Then again, under the heading of embryonal carcinomas, we have extraembryonic tumors that are arising from extraembryonic structures and tumors that are arising from embryonic structures. Tumors that are arising from extraembryonic structures are yolk sac tumors and choriocarcinoma. Tumor that is arising from embryonic structures is teratoma, mature or immature. First, let us talk about dysgerminoma. Dysgerminoma accounts for 33% of all malignant germ cell tumors. It comprises of 1 to 2% of all ovarian cancers, and most patients are children or young women. The usual presentation is with a rapidly growing abdominal mass. The symptoms sometimes can simulate pregnancy. Majority of cases are at stage 1A. Serum tumor markers like LDH are usually elevated, and also about 3 to 5% of dysgerminomas produce HCG, causing estrogenic symptoms. And the picture on the left here, we can see the gross picture where we can see dysgerminomas are large, lobulated, solid, soft, fleshy tumors with yellow, tan, or gray-white appearance. The cut surface shows areas of cystic change, hemorrhage, or necrosis. The tumors arise in the background of gonadoblastoma, and they often show calcification. Okay, now that we have dealt with this, we can see on the right the photomicrograph where we can see these germinomas resemble seminomas microscopically. They are composed of monomorphic tumor cells arranged in diffuse sheets, trabeculae, or cords as shown in this picture, or nests. They may be pseudoglandular spaces due to disc cohesion among tumor cells. Basically, whatever we have learned as testicular tumor, that is seminoma, the female counterpart of that is the dysgerminoma. The tumor cell cluster are separated by delicate fibrous septa containing T lymphocytes, and in some cases there may be well-formed lymphoid follicles. The polygonal tumor cells have well-defined cell membranes, clear or lightly staining eosinophilic cytoplasm, large vesicular nuclei, prominent nucleoli, and brisk mitotic activity. The cytoplasmic clarity is due to glycogen content. Okay, then the other germ cell tumor that is arising from the embryonic structures we have to talk about, that is teratomas. Teratomas are divided into three categories: mature, immature, and monodermal. Most benign teratomas are cystic and are often referred to as dermoid cysts because they are almost always lined by skin-like structures. Cystic teratomas are usually found in young women during the active reproductive years. Benign teratomas are bilateral in 10 to 15% of cases. Characteristically, they are unilocular cysts containing hair and sebaceous material. Sectioning reveals a thin wall lined by opaque gray-white wrinkled epidermis, frequently with protruding hair shafts. Within the wall, it is common to find grossly evident tooth structures and areas of calcification. As we can see in this very classic cross picture on the right of this slide, we have we can see this is a mature cystic teratoma, which is showing hair, sebum, and adipose tissue. That is, it is showing many epithelial structures. Therefore, we can also call it a dermoid cyst. Now we'll look at teratoma, which is not exclusively a dermoid cyst, that is, which is not showing exclusively skin like or skin adnexal structures. We can see here this is along with being a dermoid cyst, we can also see bony areas, especially on the left side of this photomicrograph, which is on the left. The right side of the photomicrograph, yes, it is showing an epithelium with keratin, but the left side of the tissue is showing some uh, bony trabecular formation. So this is a mature teratoma, uh, which need not be called a dermoid cyst. On the other side of this slide, on the right side, we have an immature teratoma. The tumor is bulky and it has a smooth external surface, and it tends to be solid on sectioning. Here, sebaceous material, cartilage, bone, and calcification may be present, along with areas of necrosis and hemorrhage. On microscopic examination, there are varying amounts of immature neuroepithelium, cartilage, bone, muscle, and other elements. So basically, you have to understand that a mature teratoma will have very much mature tissue elements that is all the elements, that is bone or cartilage or any other epithelium, you will see completely mature forms of them, and then you will call it mature teratoma. And when the majority of these tumors, majority of these components are epithelial, that is when majority of these components are skin adnexal structures, that time you call it a dermoid cyst. But when these various tissue components are showing signs of immaturity, that time you label it as immature teratoma. And lastly, under the category of teratoma, we have monodermal or specialized teratomas. The specialized teratoma are a remarkable rare group of tumors, the most common of which are struma ovary and carcinoid. They are always unilateral, although a contralateral teratoma may be present. Struma ovary is composed of entirely of mature thyroid tissue. As we can see on the first photomicrograph of this slide, uh, it may be functional and it can cause hyperthyroidism also. As we can see, easily we can make out the varying size thyroid follicles within the ovarian tissue. And on the second picture, we are seeing ovarian carcinoid, which resembles carcinoid tumors of any other part of the body. The nuclear features are of neuroendocrine tumor, which is salt, pepper, chromatin of the nuclei. Now that we have discussed teratoma, we'll look at the tumor, germ cell tumor arising from extraembryonic feature. The first one is yolk sac tumor. Though rare, yolk sac tumor, also known as endodermal sinus tumor, still ranks as the second most common malignant tumor of germ cell origin. It is thought that it is thought to be derived from malignant germ cells that are differentiating along the extraembryonic yolk sac lineage. Reticular or microcystic pattern is seen in the microscopic picture of yolk sac tumor. It is basically loose network of anastomosing channels that focally expand to form variable size cysts. These spaces are lined by primitive tumor cells with varying amounts of clear glycogenated cytoplasm, occasionally containing lipid. The most characteristic histologic feature, though, of yolk sac tumor is a glomerulus-like structure composed of central blood vessel enveloped by tumor cell within a space that is also lined by tumor cell, known as Schiller-Duval body, as we can very easily see here in the second photomicrograph. So the last germ cell tumor that we are going to discuss, that is arising from extraembryonic structures, is the choriocarcinoma. It is more commonly of placental origin. Uh, as I was saying, choriocarcinoma is more commonly of placental origin. Uh, uh, and like the yolk sac tumor, it is an example of extraembryonic differentiation of malignant germ cells. It is generally held that a germ cell origin can be confirmed only in prepubertal females because after this age, an origin from an ovarian ectopic pregnancy can be excluded. Composed of cytotrophoblast, intermediate trophoblast, and multinucleated syncytiotrophoblast around periphery of blood channels, uh, like all choriocarcinomas, they elaborate high levels of chorionic gonadotropins, which may be helpful in establishing the diagnosis of uh, or detecting recurrences. In contrast to choriocarcinomas arising in placental tissue, those arising in the ovary are generally unresponsive to chemotherapy and are often fatal. As you can see in the photomicrograph here, of the choriocarcinoma, smaller cytotrophoblastic cells are growing with syncytiotrophoblastic cells in a plexiform pattern. So now we are over with discussing the germ cell tumors and surface epithelial tumors of ovary. The last section of discussion of ovarian tumors is sex cord stromal tumors. The first tumor we'll discuss is Sertoli Leydig cell tumor. These tumors, they secrete androgen. They cause defeminization followed by masculinization of the female patient. Also lead to altered body contours. They lead to flattening of the breast. They cause scanty and irregular menses, amenorrhea, hirsutism, enlargement of clitoris. breaking of voice, and they can also become malignant. This is a gross picture of the sertoli lytic cell tumor, which is showing a solid tan yellow cut surface with foci of hemorrhages. Microscopically, a range of differentiation is seen. Well differentiated sertoli lytic cell tumors show tubules composed of sertoli cells or lytic cells interspersed with stroma, as we can see in the photomicrograph included here. The intermediate form shows only outlines of immature tubules and large eosinophilic lytic cells. The poorly differentiated tumor has a sarcomatous pattern with a disorderly disposition of epithelial cell cords. Lytic cells may be absent. The photomicrograph here is showing a well-differentiated sertoli cell tubule, therefore the well-differentiated version of sertoli cell tumor. Another one is fibroma. It constitutes of 3% of all ovarian neoplasms, can occur at any age. It is firm in consistency and harder than that than of it is harder than a uterine myoma. It undergoes degeneration and cystic spaces can be seen in the center. Usually it is 15 centimeter in diameter and it can grow up to 25 kgs. It is associated with Meeks syndrome, which includes ovarian fibroma with ascites and hydrothorax. Fibromas of the ovary are unilateral in about 90% of cases and are usually solid, spherical, or slightly lobulated, encapsulated, hard, gray-white masses covered by glistening intact ovarian serosa. On histologic examination, as we can see in this photomicrograph, they are composed of well-differentiated fibroblasts and a scant interspersed collagenous stroma. Focal areas of thecal differentiation may be identified. So basically, fibroma is the uh, tumor composed of the fibroblastic component of the tumor. Now, if we consider the spindle cell component of the ovary, tumor arising from the spindle cell component is known as the thecoma. It occurs post-menopause. It mostly is unilateral. It occurs in post-menopausal bleeding due to estrogenic effect, and it can turn malignant. Luteinization of the cells resulting in secretory hypertrophy by progesterone can occur. Tumor cells resembles that of the theca lutein cells of Graafian follicle. Here we can see the photomicrograph of thecoma. We see spindle cells with moderate pale cytoplasm containing lipid droplets and a central nuclei. Intervening stroma has collagen deposition and focal hyaline plaque formation, and some tumors are heavily calcified and may have prominent stromal hyperplasia, which is also known as hyperthecosis, as we have already discussed earlier. Next, under the sex-cord stromal tumors, we have granulosa cell tumor. It consists of 10% of all solid ovarian tumors. 80% occur in women above 40 years, 5% in prepubertal girls. It secretes estrogen. Before puberty, it causes precocious puberty, secondary sexual characteristics, hypertrophy of breast and external genitalia, pubic hair, myohyperplasia of the uterus, and anovulation. In adults, it causes exaggerated proliferative pattern, endometrial hyperplasia, or endometrial cancer, amenorrhea followed by prolonged bleeding. In postmenopausal women, it causes postmenopausal bleeding, myohyperplasia, and cystic glandular hyperplasia of the uterus. Here is a gross picture of the granulosa cell tumor. The macroscopic features mainly constitute of that it is oval, soft in consistency tumor, and approximately it is 10 centimeter in size. The microscopic features say that the granulosa cell component of these tumors can show many histologic patterns. Small cuboidal to polygonal cells can grow in anastomosing cords, sheets, or strands. As we can see in this picture that once again has been lifted directly from your Robbins. In the first part of the photo, we can see the tumor cells arranged in sheets punctuated by small follicle-like structures, which are also known as Cole-Exner bodies. The second photo is showing immunohistochemical stain with strong immunohistochemical positivity with an antibody to inhibin. Lastly, we will discuss metastatic tumors of ovary. The most common metastatic tumor of the ovary are derived from tumors of Mullerian origin of the uterus, the fallopian tube, contralateral ovary, or pelvic peritoneum. The most common extramullerian tumors metastatic to the ovary are carcinomas of the breast and gastrointestinal tract, including colon, stomach, biliary tract, and pancreas. Also included in this group are the rare cases of pseudomyxoma peritonei derived from appendiceal tumors, as we have already discussed before. A classic metastatic gastrointestinal carcinoma involving the ovaries is termed as Klukenberg tumor characterized by bilateral metastasis composed of mucin-producing signet ring cancer cells, most often of gastric origin. So, Klukenberg tumors are bilateral and most often arise from primary carcinoma of stomach 70%, large bowel 15%, breast 6%. They have smooth surface but maybe slightly bosselated surface. They're freely movable in the pelvis. There is no infiltration through the capsule and no tendency to form adhesions. The tumor retains the shape of the normal ovary and it is solid, waxy in consistency. Histologically, cellular or myxomatostroma can be seen and scattered signet ring cells can be seen. Here we have the photomicrograph. We can see majority of the tumor cells have dense eosinophilic cytoplasm and hyperchromatic irregular nuclei. Signet ring cells are present in scattered foci. The primary tumor for this can be a gastric adenocarcinoma. That's it for your class. Uh, any doubts you can text me over WhatsApp. Any doubts you can text me over WhatsApp through the personal chat or in the group, in the WhatsApp group for all of you. Thank you.